Good afternoon, everyone. So I'll be discussing about intermittent exotropias. So intermittent exotropia is a large phoria that is intermittently controlled by fusional convergence. Von Nuden said that 75% of 51 untreated patients in the age group of 5 to 10 years of age, they showed progression over a follow-up period of 3.5 years. But some studies say that if for a longer period we see the follow-up, then some patients, they show improvement also. So there are various phases of exodeviations. Like in phase 1, there is exophoria at distance, orthophoria at near, and these patients are asymptomatic. Then in phase 2, intermittent exotropia is present for distance, orthophoria or exophoria present at near. These patients are symptomatic for distance. Then phase 3, exotropia is there for distance, exophoria or intermittent exotropia at near. Binocular vision is maintained for near in these patients with suppression scotoma at the distance. And in phase 4, exotropia is present at both distance and near, and there is lack of binocularity. So what is the etiology behind intermittent divergence squint? So there can be innervational factors, like there is an imbalance in convergence and divergence mechanisms, or there can be some mechanical factors like the position of the orbits or the position of the extraocular muscles. There has been seen a role of defective fusion, and the patients of intermittent exotropias are also seen to be associated with high AC by A ratio. And theory of hemiretinal suppression has seen to be associated, like there is temporal retina suppression in these patients, and there is a role of refractive errors also. Like in high myope patients, they don't need much accommodation. So those patients, they have a tendency, eyes to go out. And in high hypermetropes, due to decreased vision, these patients are not able to accommodate. So obviously, then also these eyes have the tendency to go out. So there are some sensory adaptations in these patients. In tropic phase, most of the patients, they show large suppression of the temporal retina. Anomalous retinal correspondence is seen in the tropic phase, and normal retinal correspondence is seen in phoric phase. Some patients also develop monofixation syndrome, and these patients do not have normal bifoveal fixation, but they have high grade of stereopsis present. Some patients may develop even significant amount of amblyopia, and if there is a late onset of exotropias, that is after 6 to 7 years, when the children, the age of the plasticity has gone. So these patients, they experience diplopia also. So there are two types of classifications which we generally follow in these patients. First is the Burian's classification, which has basic type, divergence excess type, convergence insufficiency type, and simulated or pseudo-divergence excess type. Another classification is the Kushner's classification, in which there is basic type, in which distance deviation is equal to near deviation, that is present in about 37% people. Then if there is a role of tenacious proximal fusion, that is in those patients the distance deviation seems to be more than near deviation, but after 60 minutes or 30 minutes of occlusion, both the deviations become equal, and it is present in about 40% people. And there is like other classification, other groups also, like high AC by A ratio, proximal convergence, people having low AC by A ratio. So these are classified accordingly. So this is the Kushner's classification. There is a role of genetics also in this. So the children of intermittent exotropias, they can have a positive family history. Craniofacial anomalies and neurological defects are also seen to be associated. And maternal smoking during pregnancy and low birth weight are the risk factors for this. So what has been the age of onset in these patients? So Burian and Spivey, they reported that there is 63% of the patients, they present at the age of, their age of onset is less than 5 years of age. And out of those, 35 to 40% patients, they are presenting before second year of life. And female preponderance is more in these patients. The precipitating factors are like when the child is daydreaming, or when the child is tired, or when the child is sick, then it becomes manifest. So how to elicit? In this we can see that there is a divergent squint, and when the patient focuses, so the eyes become orthophoric. So what are the symptoms? There can be transient diplopia, there can be asthenopic symptoms, There can be diplophotophobia. This is seen to be present because when the light is there on the retina, then it dazzles the temporal retina and the child can experience diplophotophobia, and micropsia is due to the role of high AC by A ratio. So these patients, it is very important to test stereopsis, both near and distant stereopsis. Motor control plays an important role. So there is a revised Newcastle score for this, in that we check for the home control and the office control. In home control, grade 0 is when there is no deviation present at any time. Grade 1 is when it is present in less than 50% of the times fixing that at distance. Grade 2 is when it is fixing more than 50% of the times at distance, and grade 3 is when it is present more than 50% times in both distance and near. And in clinic control, it is for both near and distance. That is, if it immediately realigns after dissociation, it is grade 0. If it realigns after a blink, it is grade 1. If it remains manifested after dissociation, it is grade 2. And if it manifests spontaneously, it is grade 3. So it is very important to measure the angle of deviation. It is done by patch test, which differentiates pseudo divergence excess from true divergence excess, and then we do the +3 diopter. We apply +3 diopter lens to check for if there is any high AC by A ratio present or not. So does conservative management really works? Conservative management, we give it in those patients who have less amount of deviation. Like we can give prisms of up to about 20 prism diopters, and we can prescribe some fusional exercises also. So refractive management is important. We give full myopic corrections, full astigmatic corrections, and in hypermetropes, if they are not corrected, then they can stimulate accommodation and
You'll
convergence.
Have to conclude, please, because
yes,
we're already 9 minutes now.
So such patients, the amblyopia is also need to be treated for improving the control also, but this is still controversial whether it improves intermittent divergent squint or not. We can prescribe minus lenses also, but they have to be eventually discontinued. We have to see the progression of intermittent divergent squint. If it is progressing, then we have to go ahead for surgeries. So these patients, there is a controversy whether to operate in early ages or whether to operate on later ages.
Please sum up, please sum up.
Yes, sir. So the goal of the surgery should be to realign the binocularity and basically not to develop amblyopia, and so that the children have their preserved stereopsis also. So there are a lot of controversial issues in this, so we need to treat these patients very wisely. Thank you so much.
Thank you. I'll just give you a piece of advice. You should show more about the cases. This is mainly theoretical. See, yes. This is not a PG class or this. Please don't mind. But I would advise you that in the next papers, you should show more practical the cases where you see what type of intermittent and the excess true divergence, pseudo divergence, or whatever it is. Like that, you should show something on that. Thank you very much.